today we're just having a pretty casual discussion on this one case that we had. Seems like we had left ventricular thrombus from a case of viral myocarditis. So, I mean, our objectives here are basically just to highlight, sort of the complex viral myocarditis etiology, pathophysiology, and how different management strategies can lead to better outcomes. So, I know this slide is a bit busy, so I've basically broken up the presentation into smaller chunks. So basically, we start with this one, which is the case presentation, right? So we had this 53-year-old female, just history of hypertension and tobacco use, like how we have all our patients here. Just comes with just 3 weeks of his just shortness of breath and swelling of the feet. So initially we thought, this seems like an acute onset of heart failure that's new. She's pretty young to have heart failure. And her clinical exam in the ED just showed just she was hypoxic, requiring oxygen, and just crackles in her lung and just bilateral pedal edema. So our assessment was basically that of heart failure at that time. So if you look up at that EKG section, basically she was also in a new onset atrial flutter. So with that irregular rhythm, heart failure kind of picture, we just brought this patient into our telemetry unit, just taking a look at how she's doing. We got the X-ray, and you can take a look at that X-ray, just some fluffy opacities, suggestive of, again, heart failure. And she had a BNP elevation as well. So also got a CT chest, again, just testing our theory that there's a lot of fluid overload going on right now. And with her new onset atrial flutter and this new onset heart failure, we also got a stat echocardiogram. So echocardiogram showed, and this is the very interesting part of this case, is that if you take a look at the middle image right there, you'll see the left ventricle, and you'll see an apical thrombus, and that actually just looks like the size of my thumbs, honestly. And it seems like that apical thrombus was just, mobile thrombus that was moving, and this patient had an EF of less than 15. So she was doing pretty poorly initially, and we brought her to the ICU. We started on a multitude of treatments such as nitroglycerin, heparin, furosemide, amiodarone, and broad spectrum antibiotics. So it required a lot of cardiology and pulmonary support. And sort of the idea was we need to dissolve that clot, because if it gets lodged somewhere else, it probably causes stroke or something. We need to control her blood pressure and get that fluid out. So that was the initial plan. And obviously, just we're thinking about it, right? So we're thinking, why would this patient so young go suddenly in heart failure, go suddenly in atrial flutter without a cause, right? So we tried to look back at what would cause it. So if you look at her history back, this has all happened in the 3 days, right? And now, while she didn't complain of any flus or any fever-like symptoms, we were looking at what causes a rapid onset cardiomyopathy, right? So cardiomyopathy, typically we would think, since, based on her other risk factors, could it be just hypertension, right? So hypertension would require something like 10 years for it to lead to that. Could it be just tobacco use or other drug use? And her urine drug screen was negative. So then we looked at additional causes such as viral etiologies. So we sort of started the workup of all the viruses, including Coxsackie, EBV, parvovirus, CMV, and basically also looked at hypercoagulable states. So hypercoagulable states can also lead to just formation of thrombus, and we'll get to how they do that, right? And so those all were negative. So if you take a look at the next slide, this is what we're looking at, right? So we again start with the most basic thing, that's the Vogiatzis triad, right? Stasis, endothelial damage, hypercoagulability. Any clot to be formed in the body, you have to meet that condition, right? So stasis, definitely with the flutter situation going on, the atrioventricular desynchrony could be causing some stasis, right? Endothelial damage is what we need to figure out, right? And we'll reach there. And then hypercoagulability, obviously, by the byproduct of stasis and endothelial damage. So that triad always goes hand in hand, right? So if you look at it, we basically had test results come positive for CMV. Okay, so CMV, cytomegalovirus, is a very rare cause of viral myocarditis. And if you look at it, myocarditis basically affects 10 to 20 people per 100,000. Post-viral myocarditis, only 1 to 5% of those patients. And having a thrombus in post-viral myocarditis, there's only case reports. It's extremely rare. So, but usually how we do it is let's look at the common things being common, right? So there's no history of thrombus. She doesn't have a history of heart failure or A-flutter. Again, this is all new onset, acute onset. There's no history of hypercoagulable states. We did that hypercoagulable panel, right? There's no history of cancers, which can also lead to that. No family history of any sort of clots or myocarditis or cardiomyopathy. There's no coronary artery disease, which we'll get to. And then blood culture is sterile for bacterial and fungal growth. So basically ruling out the basic common causes, we reached the diagnosis of viral myocarditis. And so then we sort of looked at the literature, right? So it seems like CMV, while not common, can lead to myocarditis. And that's how the theory came in of endothelial damage, if you look at the diagram. And obviously, turbulent flow just makes that trifecta Vogiatzis triad condition met. And that's how basically this patient had a clot. So what we also want to highlight is if you look at viral myocarditis, the commonest causes would be, from commonest to rarest, would be adenovirus, and then sort of goes down the list: coxsackie, parvovirus, HHV, CMV, Epstein-Barr, and so on. So main thing to know is this patient then went back into flutter, and we also did a cardiac cath. So the cardiac cath actually led to no coronary artery disease. She actually had a clean catheterization. So that excluded coronary artery disease as well, which could lead to this. So again, we couldn't start any treatment for her because this patient incidentally went AMA, went against medical advice. So as they always do at 53, and you just start treating them. But basically our idea was just to show the challenges and the management you can do in a viral myocarditis and how it can lead to these sort of complications. So that's our case.